This morning we're going to talk a little bit about the immune system and how problems or issues with the immune system can affect many children with Jacobsen syndrome. I think I've done this talk at Jacobsen syndrome meetings now for more than 10 years. And while some things have changed, a lot of them have stayed the same. And it's important to constantly review this information because we always have new families. Sure. So we always have new families that attend, and I'm aware that today there are 3 new families here who might benefit from hearing all about the immune system. So I have 3 objectives for this morning. When we finish up around 10:30 or so, I want people to be familiar with the immune system in children and adults. I don't expect people to be experts, but I want you to be familiar with some of the terms, some of the parts of our immune system, and how they might be different in patients with Jacobsen syndrome. I also want people to come home with some information about ways and recommendations for keeping your children healthy and hopefully free or at least with reduced numbers of infections. Okay, so what is our immune system? So our immune system keeps most people healthy most of the time. We all get sick every once in a while, right? We all might need to take antibiotics to get well. But in general, most people are healthy for the majority of their life. And the way our immune system does that is with different types of cells, proteins, and in fact, body organs that work together or sometimes separately to protect us from infections. And it's happening all the time, whether we know it or not. We're constantly exposed to bacteria or viruses, and our immune system is working to protect us from infections. Our immune system does this by recognizing danger signals. Danger signals are bacteria, viruses, fungus, or other pathogens that we're exposed to on a daily basis. This picture is actually a food particle, and it's covered with bacteria. And I put this in my talk to remind people that we're constantly exposed to these types of pathogens, and our immune system is constantly recognizing them, fighting them off, and protecting us from infection. So one problem with immunology as a specialty in medical school is that it's the least popular for medical students in their training years. And if this were a medical school of maybe 100 or 200 people, this is about all of the students who would show up for the immunology class. And at the end of the session, probably the front row would be the only people left. And unfortunately, and I make a joke about that, but unfortunately, that impacts a lot of the physicians who take care of your children. So unless you are interested in immunology, you may not have ever paid attention to the class where you were supposed to learn about these cells. And after you're out seeing patients in the real world as a physician, you might never think about the immune system again or the different problems that can occur, for example, in patients with Jacobsen syndrome. In some ways, at the end of this session, you might know a little bit more than your pediatrician or your physician about the problems that you might see in Jacobsen syndrome. So let's get started. Okay. So to make this easy, these are little cartoons about the different parts of our immune system. So I mentioned this already, and our immune system needs to recognize some sort of danger signal or enemy. It can come in different forms. I mentioned bacteria or viruses, which are the most common causes or the most common types of danger signals. But also, fungus or fungi can be a big problem for infections of the skin. Physical barriers are also an important component of our immune system. The biggest immune system organ in our body is actually our skin. It acts as a physical barrier and shields our organs, our bloodstream, and other parts of our body from pathogens like bacteria and viruses. Our mouth, our nose, our middle ear are covered by mucous membranes, which protect us from invasion with bacteria and viruses by secreting proteins and cells that immediately neutralize or kill those danger signals before they infect us. These body fluids are very important in the initial response to infections, and they sometimes can even flush bad guys or danger signals away before infections set in. The most important cell in our immune system is called a T cell. This is the cell that sometimes is abnormal in patients with Jacobsen syndrome. And it has two very important roles in the immune response to pathogens. First, it communicates with other cells by secreting chemicals and proteins that tell them what to do. And we call it the communication link of the immune system. Certain types of T cells also directly kill the bacteria or viruses before they can infect our bodies. And you can imagine if our T cells are damaged or broken, or if we don't have T cells at all, our immune systems are crippled and unable to respond to infections. Those T cells, I mentioned, secrete proteins and chemicals that talk to other cells. And the cell they talk to most are called B cells. These B cells are important because they secrete neutralizing and killing antibodies which defend us from bacteria and viruses. And they function over a long period of time to produce those antibodies. Some B cells make the initial response to an infection by secreting a type of antibody, which I'll mention in the next slide. And other B cells live for long periods of time, secrete antibodies that protect us for years and years so that we don't get the same infection more than 2 times. I'll mention in a slide coming up that B cells might also be abnormal in patients with Jacobsen syndrome. And we know this because of the research that Dr. Dalm did at Rotterdam in the Netherlands. Antibodies are very important in protecting us from infections. These are proteins that are secreted by B cells and that circulate in our bloodstream all the time, 24/7. Each antibody that is made by a B cell is specific for a unique bacteria or virus. These immediately kill bacteria and viruses. They can neutralize the toxins that bacteria or viruses secrete that cause damage to our cells. And they also stick to the bacteria after they're killed and allow for our immune system to clear those bacteria or dead cells away and allow for our organs to heal after an infection. So you can imagine if we don't make protective antibodies, our immune system is crippled. It can't protect us from infection, and if an infection occurs, that infection will probably last longer and have more consequences for our organs. And so all these cells, the T cells, our B cells, our antibodies, and then other components I didn't mention, act like a team. They have a very organized way of responding to infections, killing bacteria and viruses, and then cleaning up the mess when everything is done. And unfortunately, in Jacobsen syndrome, that team doesn't really talk to each other and is probably abnormal in almost all patients. When our immune system doesn't work well, we have a name for that, and it's called immune deficiency. Our knowledge about the immune system in Jacobsen has evolved tremendously over the last 10 to 15 years. Before I saw my first patient with Jacobsen syndrome, physicians recognized that patients with 11q deletions got sick more frequently. They had more infections of the ears and of the sinuses, but what they believed was that those infections were the result of abnormal skull formation, right? The facial bones probably weren't formed in the correct way, and bacteria and viruses were able to live in the middle ear or in the sinus cavities and evade the immune system. But soon, some physicians realized that patients with Jacobsen syndrome might also have low antibody levels. Some patients with Jacobsen syndrome were treated with immunoglobulin replacement or antibody replacement. But it wasn't recognized that many patients with Jacobsen syndrome were susceptible to infections and probably had abnormal immune systems. Only in about 2010 was it realized that infants were born with Jacobsen syndrome, and when they were born, their immune system was already damaged. This occurred when, in the United States, we began screening for immune deficiencies in many children in different states. That test was designed to identify patients who did not have any T cells, which I mentioned earlier. And occasionally, a patient was born who didn't have the disease that the test was looking for, but instead had Jacobsen syndrome. And so they quickly realized that some patients with Jacobsen syndrome were born with very low T cell numbers. And since that time, we've realized that many patients with Jacobsen syndrome, and probably all patients with 11q deletions, have some form of an immune deficiency and are susceptible to infections. So how do we test for immune deficiency in Jacobsen syndrome? Okay. So unfortunately, the only way that we can test for immune deficiencies is with blood samples. Testing typically requires a blood sample on different occasions, so on multiple days. And we usually do this in a stepwise approach, which I'll mention in a future slide. Blood testing is required to measure those T cells and B cells and make sure that they're present in the normal numbers. And we also need to test to see whether those T cells and B cells function normally. And we do that by using a special vaccine and measure children's response to immunization. We can measure antibody levels before receiving the vaccine and then afterwards, and then compare that to what we would normally expect in other healthy children. Okay. So what symptoms in 11q deletions might suggest immune deficiencies? I'm sure that when I go through this list, some of you will recognize these symptoms in your own children. I mentioned before, many children with Jacobsen syndrome have chronic upper respiratory tract infections. This includes ear infections that require antibiotics, sinus infections, and also lung infections. Some patients might have chronic diarrhea. It's very common for patients with T-cell deficiencies, which is what we see in Jacobsen syndrome, to have skin infections with Candida or other types of fungus. This picture is of a skin infection with a fungus that in the US we call ringworm or tinea. It's a very common infection in children, but usually it goes away very quickly. What we might see in patients with Jacobsen syndrome is difficult to treat, and it can impact or affect especially the feet for many, many years in patients with Jacobsen syndrome. We've recognized that patients, especially in Dr. Dahlm's cohort of children and adults, have recurrent or severe warts of the hands and of the feet. In normal children, these warts typically only last several months, and treatment with chemicals or physical destruction often leads to cure. But in patients with Jacobsen syndrome, these warts can last for years, and they can last long into adulthood. Okay. So there are three main types of immune deficiencies that we see in patients with Jacobsen syndrome. As immunologists, we have names for them, and I think it's important that you be familiar with these terms so you can ask your physicians if they've done the testing to make these diagnoses. The first type of immune deficiency is called hypogammaglobulinemia, and it's a very general term where we describe patients with low antibody levels. If a patient has hypogammaglobulinemia, it means that their B cells are not able to function to make those antibodies. And it might be a deficiency in any one of the three different types of antibodies that I list here: IgG, IgA, or IgM, or sometimes a combination of more than one of those antibodies. Patients with low antibody levels typically have recurrent infections of the ears, sinus, and lungs, but they don't have warts or other skin infections that I mentioned in the last slide. Most of the patients with mild or moderate hypogammaglobulinemia respond to treatment with antibiotics or sometimes with replacement of those antibodies in the form of immunoglobulin. The treatment with antibiotics can sometimes be done with long-term dosing over months to prevent infections, or sometimes with use of antibiotics only when infections occur. The second type of immunodeficiency that we see in patients with Jacobsen syndrome is called lymphopenia. Typically, it's T-cell lymphopenia, and it occurs when patients have low T-cell counts or the T-cells that they do have don't function normally. These patients are the patients who have recurrent skin infections with viruses such as warts or fungus. And while the infections can usually be treated with medications, the T-cell deficiency cannot be corrected, and the deficiency is typically lifelong. And there's a third type of immune deficiency where both there is a B-cell problem and a T-cell problem, and they have low levels of antibodies and usually some sort of T-cell deficiency. These patients have a combination of infections, so they have recurrent ear, sinus, and lung infections, and sometimes skin infections or other problems of the immune system. These are usually treated with antibody replacement in the form of immunoglobulin infusions, which I know some patients are receiving in the room today, and also with antibiotics to both prevent and treat those infections. So we have hypogammaglobulinemia. I know some patients in the room who have that. Lymphopenia. In the US, I know a patient who has very low T-cell counts, and I'm sure some patients here today also have low T-cell counts. And then common variable immune deficiency. We often will see it written in the medical record as CVID, or CVD, depending on the country that you live in. Some countries use different acronyms or names. Okay. The last slide is relatively old news now. We've known about those different problems for about 10 to 15 years. But this is a little bit more recent. And so initially we thought that the deficiencies seen in Jacobsen syndrome were from T-cell problems. Either T-cells didn't communicate with B-cells, or T-cells weren't present at all and unable to do the job. And it led to a B-cell problem where they didn't make antibodies. But we now know that there's probably some component that impacts the B-cells either directly or the signal from the T-cell prevents B-cells from developing normally themselves. So there is a form of a B-cell called a memory B-cell. And I mentioned before that those are B-cells that produce antibodies to protect us long term. They're constantly making antibodies so that we don't become sick with an infection we have seen before. And what Dr. Dahm showed in Rotterdam with his team is that there is a subset of B cells called memory B cells, which are deficient in almost all patients with Jacobsen syndrome. And I don't have my pointer, but the graph on the left side of the screen shows a group of normal patients. Let's see. So these patients here are normal patients. And in general, they make normal or high levels of those memory B cells. These are Jacobsen syndrome patients. And you can see, oh, they can't hear, sorry. So these are normal patients. They make normal levels of memory B cells, and they make normal antibody levels. These are Jacobsen syndrome patients. They make very low or no memory B cells, and because of that, they either make low levels of antibody or they don't produce those long-term protective antibodies that will prevent infection with bacteria or viruses that second time. And it explains why patients with Jacobsen syndrome sometimes need to be treated with antibiotics for many, many weeks in order to clear infections. And after infections are treated, they come back. And so that's new information that I think everyone needs to be familiar with, because we can test for those memory B cells now. And 10 years ago, we did not have that ability. So the way that we've recognized children with immune deficiencies in Jacobsen syndrome has changed dramatically over the past 10 to 15 years. And I put this slide just so that you can understand how all of these how this new understanding of immune deficiency and Jacobsen syndrome can benefit all the newly diagnosed patients. So in the past, patients were born and they were recognized to have Jacobsen syndrome because of a heart defect, or abnormal facial structure, or low platelets. They were then cared for by pediatricians, by cardiologists, and maybe a few patients were referred to an immunologist for an evaluation because they had recurrent infections. And maybe laboratory testing was done, and maybe those patients were identified as having an immune deficiency. But now that newborn screening is standard in all states in the US, and also standard in many countries in the EU, that may be an opportunity to identify a patient with an immune deficiency very early on. And even if the test doesn't identify a patient at birth, the information that we now have and the way that immunologists understand Jacobsen syndrome might lead to much earlier diagnosis of patients. And so conferences like this today can help all the children with Jacobsen syndrome get the evaluation that they need to identify any problem or deficiency in their immune system. So in 2017, Virgil and I got together with Paul, and we talked about what we could do to make the evaluation of these patients with Jacobsen syndrome a little bit easier, right? There was already a protocol for treatment of bleeding prior to surgeries and other interventions, and we felt that developing an immunology protocol might be beneficial as well. And so we put together some guidelines, and this protocol is available on the web. It's a PDF file. You can download and print it, and you can bring it to your pediatrician, and you can make sure that he or she has done all of the required testing or ask for a referral to an immunologist so this testing can be done. I think all newborns, once the diagnosis of Jacobsen syndrome is made, should have T cells measured, either by the newborn screening test or by measurement of T cells via a separate blood sample. This can be done soon after birth, and it can help us understand whether there might be a very severe deficiency in the newborn patients. Around the age of 4 to 6 months, we can measure immunoglobulins or antibody levels. And at 12 months, we can test to see if the immune system of patients is functioning to respond to vaccinations. And so we measure the antibody levels for the vaccine preventable diseases such as tetanus and diphtheria. And around 2 years of age, we can measure to see if they respond to vaccination with Pneumovax. That's a vaccine that's used in all kids to protect against a common bacteria that can cause ear and sinus infections. By giving Pneumovax and measuring children's response to that vaccine, we can do two things. First, we can protect them from infection with that bacteria, and that will reduce the frequency that they get ear infections and sinus infections. And we can also challenge or measure their response and make sure that their immune system is functioning normally. Our protocol also recommends a consultation with an immunologist. And there's a list of immunologists on a few websites that I will provide at the end of this talk today. And that's in almost all countries in the EU. In general, routine vaccinations are safe and effective for patients with Jacobsen syndrome, unless there is a known severe T cell deficiency. So patients who are born, who are identified as having a severe T cell deficiency at birth, can receive all of the normal childhood vaccinations, with the exception of the vaccine for rotavirus, if it's available in your country, or the MMR vaccine, measles, mumps, rubella, or the varicella vaccine. So to repeat, most childhood immunizations are okay. I would wait to get rotavirus, MMR, or varicella. Almost all children with Jacobsen syndrome can get those three vaccines eventually, but in the first year or two of life, it's best to wait until your immune system has been fully tested by an immunologist and we understand the extent of the immune deficiency that they may or may not have. It came to Paul's attention years ago that a patient with Jacobsen syndrome had severe illness with RSV, which is a common virus that affects children and causes, in most kids, a mild to moderate respiratory tract infection. But he had heard about a patient with Jacobsen syndrome who had a very severe course and unfortunately passed away from that infection. And so in talking with Virgil and I, we felt that we needed to strongly consider the use of a medication called Synagis, which can protect infants from that disease and hopefully prevent that very tragic consequence that that child suffered from. This medication called Synagis is already used for patients with congenital heart defects in the first year or so of life because they're at high risk for severe RSV infections. And many children with Jacobsen syndrome have heart disease and are already taking Synagis in that first year or so. But we know that not every child with Jacobsen syndrome needs congenital heart surgery. And so using this in all patients with Jacobsen syndrome might be a big benefit and prevent RSV. And I also mentioned in a previous slide, using Pneumovax in all patients to both prevent infection with that bacteria and also challenge their immune system so that we can identify the presence of an immune deficiency. I think when most people go to their pediatrician with an infection, they leave with some sort of antibiotic prescription. It's very common. But sometimes pediatricians will wait a while and not give you that prescription for antibiotics. And I think that's probably fine in most children. But in patients with Jacobsen syndrome, I would advocate the opposite. We know they have an immune deficiency. We know they get recurrent infections. And so as physicians, it's our job to treat those early so we can prevent the complications. I also think it's important to use antibiotics for longer periods of time in patients with Jacobsen syndrome. And so for families who have a child with Jacobsen syndrome and then other children without, you might see a difference in the way that they respond to antibiotics. Patients with immune deficiencies commonly need higher doses of antibiotics or longer periods of treatment in order to get well. Where normal children can get a 7 or 10-day course of antibiotics, clear their infection, and be back to normal quickly. Sometimes immune deficiencies take a while to present on blood testing. What might be normal early in life can change, and as years go by, we may notice that the B cells stop producing antibodies, or children start getting infections with bacteria more frequently. And so if you notice a change in your child's overall health, typically infections that start to become more frequent or more severe, it's important to revisit an immunologist or your pediatrician and ask for retesting to see if those blood tests have changed. And then I talked earlier yesterday with a few different families about the use of prophylactic antibiotics. Prophylactic antibiotics are important for use in patients with immune deficiencies because it can prevent infections before they begin. Prophylactic antibiotics are used in all patients with low T cells because they're susceptible to different types of infections than normal children. And even if your T cells are normal in number, prophylactic antibiotics can reduce the frequency of ear and sinus infections that we commonly see in patients with Jacobsen syndrome. There are different regimens that can be used. Some of the antibiotics can be given daily, for example, Bactrim or amoxicillin. And there's another form called azithromycin, which can be used 3 days a week, once a day. So depending on your child's other health concerns, one of those antibiotics can be very helpful in reducing the frequency of infections. And I promised that this year we would finally maybe update that protocol with some new information. I'll save everyone a talk about COVID. We did that last time. But there's a few things I do want to put in that protocol. After the US meeting in June, I plan to do a formal update of the protocol and have it published on the website. But here's what I'm proposing in terms of new information. Number one, I'd like to add some information about the memory B cells. That test is now pretty readily available in many different laboratories around the world. And if it's not available in a commercial laboratory in your country, I know that a research immunologist can fairly easily do it at one of the centers in the EU. So where before we didn't put it in the protocol because it was hard to find that test, in 2024, it's pretty standard to do that test on all children with Jacobsen syndrome. COVID vaccination. Rather than give specifics about the use of COVID vaccines in Jacobsen syndrome, we know that Jacobsen syndrome is an immune deficiency disorder, and you should follow the COVID vaccination recommendations in your country based upon the licensed products and the prevalence of the disease. And using antiviral medications for illness with COVID is also important based upon the age and the risk factors that they might have. And we should consider Jacobsen syndrome patients as being high risk for COVID infection based upon their immune deficiencies, and they should get treated with antivirals as early as possible. Okay, so in summary, our immune system is very complex. You don't need to remember everything that we talked about today. If you remember the words T cells, B cells, and antibodies, I think that's a win. And if you remember that the T cells and B cells talk to each other and make those antibodies, that's even a bigger win. All patients with Jacobsen syndrome probably have some form of immune deficiency. We may not be able to measure that in the blood testing we do. We may not see a low T cell count. We may not see low antibody levels. But we know that those T cells might not work perfectly, and those antibodies might not fully protect us from infections. And so the paper that Virgil published was very important because it made a very bold statement that Jacobsen syndrome is a syndromic immune deficiency. And what that does is it allows your physicians to treat your children with either immunoglobulin replacement or antibiotics to prevent infections without questioning from the healthcare system. We're still unsure about how that immune deficiency might present itself in different patients. We don't know how we can predict which patients might have severe infections or profound immune deficiency compared to patients who might have more normal appearing immune systems. That's research that still needs to be done. But I think it's very clear that all patients with Jacobsen syndrome need to have that immune evaluation done and be under the care of an immunologist to both prevent and treat infections. And with that, I'll leave this slide as my final slide. And this is some resources that people can use to find an immunologist in your country or in your city. Some of these immunologists partner with the Jeffrey Modell Foundation, which is a global foundation dedicated to the identification and treatment of patients with immune deficiencies. I helped a family yesterday by getting on the JMF website and identifying an immunologist in Belgium. I emailed her, and within an hour, she emailed me back, and she will contact the family for an appointment as soon as they can. The Immune Deficiency Foundation is an organization in the United States, which is a patient and family advocacy organization. They also have a list of physicians. And their counterpart in the EU is IPOPI, or the International Patient Organization for Primary Immunodeficiency. I encourage everyone to take a look at one or more of these websites and see if they have a program or information that might benefit your family or your children, especially if your children have a known immunodeficiency or are receiving immunoglobulin replacement. They have lots of resources on any of these websites. IPOPI has a conference that moves around the EU for patients and families. And in the US, the Immune Deficiency Foundation has the same. And with that, I'm going to hold on questions because we're going to take a quick break. 10 minutes, Camille? 10, 15 minutes? Think about questions you might have for me when we return. If you want to write some questions down on a piece of paper, that would be fine. I can give that to the translators, and then we can translate all the questions, and I will do my best to answer them. Yep, so Camille has some papers and pens. Sebastian's going to take a note taker. And we can write the questions there when we're done. Perfect, yeah. Good. I don't need to